The triage nurse took one look at him and said, not liking that vibe, and took him directly back to the room. They did a 12-lead EKG. Appropriately, he's having chest pain and he's diaphoretic. The EKG showed ST segment elevations and leads V2 through V4. Hey there. I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response RN podcast. Today we're talking through a full journey of a STEMI patient, starting from the ER, then to the Cath Lab, and then to the ICU. You'll hear from Caitlyn, a Cath Lab nurse who lives at the intersection of adrenaline and precision, and Sarah Vance, an ICU nurse who expertly guides patients through the critical hours after intervention. We're going to break down a high-risk case, talk complications, communication, continuity of care, and hopefully spotlight the incredible role that nurses play at every step. So Caitlyn and Sarah, welcome to the podcast.
Thank you.
Thank you, Sarah. I'm so excited to be here and join you once again on the Rapid Response podcast. And I'm excited to have Caitlyn here with us. This is going to be really exciting.
I know. This is going to be great. So just a little backstory for my audience. This episode was birthed because of a question that I received in my DMs asking about what makes a PCI high risk, which is a great question. And I love telling stories to teach critical concepts, but I got to thinking, this story would be much better if told from a few different perspectives. And though I have worked at CVICU, it was 10 years ago. And most recently, I worked in the ER, but my friend Caitlyn currently works in the Cath Lab, and my buddy Sarah formerly worked Cath Lab and now works ICU and happens to love mechanical circulatory devices. So I phoned a friend, or two actually, so that I could bring you the most well-rounded version of this story today. So I hope you'll stick around with us to nerd out with the three of us about all things coronary occlusions and complications and how to care for this high-risk patient. So before we dive into the case, I just wanted to take a minute for my guests to introduce themselves and share a little bit about their background. You know, if you've listened to my podcast for a while or follow me on social media, you probably already know my friend Sarah Vance, also known as ICU nurse. But Sarah, can you just give a quick summary of your nursing background? What led you to this point today?
Yes. So as she said, my name is Sarah Vance. You may know me on social media as ICU nurse with, as far as like vision, that's how I spell it. But yeah, so I have over 16 years of working in critical care, specifically ICU, in a variety of ICUs. I did do a brief hiatus right before the pandemic. I was actually working in the cardiac cath lab, and it was such a great experience to have to bring back to my time going back to critical care and working in an ICU, because it really helped me get a different perspective of the work they do in the cardiac cath lab and really helped me fine tune my understanding and skills when it came to the cardiac system. Nonetheless, shortly after the pandemic, I stepped into a facility educator role where I really found my passion. And that's where I am today as far as teaching critical care nurses and empowering them to just really feel confident in the care that they are giving to patients and being a really strong advocate. So really understanding why we're doing the doing. That's what I'm really all about.
I love it. Why we're doing the doing.
Yes.
That's it. Oh, I love that phrase. I'll have to use that again, Sarah. All right. And then Caitlyn, I actually found you because of social media, also because of your beautiful ICU Notes by Caitlyn.
Thank you.
But aside from being a talented artist, what else are you up to in the nursing world these days?
So right now I'm actually working with Artery Inc. So they helped me design some t-shirts for my business. So I've been trying to move more into adding other things just besides my notes. So I'm actually working on recording narrated videos similar to like you guys do, just to kind of explain topics behind my note sheets, because I think it could
That's awesome.
give it like more perspective. And then, like I said, I'm making t-shirts, and I also made some scrub caps with my drawings on them. So I'm selling those. And I'm also writing 2 articles for Cath Lab Digest. So that's going to be published in their August edition and then in the fall.
Awesome. And then you just came off shift, right? Like you just finished shift in the Cath Lab
Yes.
before this recording.
So if I sound a little tired, I apologize in advance.
Well, it's so good to have you both. I'm glad you're bringing your expertise to this case. All right, let's dive in. So our patient today, ladies, is Mr. James. He is a 62-year-old male. Medical history of hypertension, diabetes, CKD stage 3. He has a reduced ejection fraction of only 35% because of a prior in STEMI. Patient states he's had 3 heart stents. All right. So he drove himself
Classic.
with his chest pain radiating to his jaw. And he arrived to the ER diaphoretic. Heart rate was 110. The triage nurse took one look at him and said, not liking that vibe, and took him directly back to the room. They did a 12-lead EKG. Appropriately, he's having chest pain and he's diaphoretic. The EKG showed ST segment elevations and leads V2 through V4. Okay, in an ideal world, we would just activate the STEMI alert, the Cath Lab would have the table open and ready, and we could just roll them on over for PCI. But today, this is not an ideal situation. For this case, it is 5 a.m. And so the Cath Lab team is at home in their beds. And this patient is going to get a little unstable on us while waiting for the Cath Lab to arrive. That's what we're talking about today. So let's talk about what are some of the priorities for an ER nurse who's managing patients who are having ST segment elevation, myocardial infarction. Okay, first off, 12-lead EKG. We need to see if this chest pain is truly from an acute coronary syndrome or some other cause, because there are so many other causes of chest pain. In fact, most patients that come to the ER with chest pain are not having a STEMI. So we got to rule out the STEMI first and then move on to look for other things. All right. Next, we need to get this patient on the monitor and ideally on the defibrillator, because heart muscle that is lacking oxygen can get a little irritable. And these patients often go from talking to you to V-fib without any warning, like no warning at all. They're not like, oh, I'm about to go to V-fib. They just talk and then bam, V-fib. Okay, so have the pads on and ready to shock if needed. And just a little side note, if you're going to place those defib pads, the Cath Lab might have a preference for where you place the defib pads. So Sarah and Caitlyn, what is y'all's experience? Do you have any opinions or recommendations for pad placement on patients who we are anticipating going to PCI?
Yeah, anterior, posterior can be a little bit hard because, the defibrillation pads that we have aren't radio translucent. So the problem is that it can get in the way of the x-ray. So a lot of times, that's great that the patient comes down with pads, but usually we have to end up taking them off and putting them on the right way. But it's just because of a knowledge deficit, because I didn't know that prior to going to the Cath Lab either.
How about you, Sarah?
Yeah. So in my facility, when I worked in the cardiac cath lab, usually ours is going to be one on the high right shoulder and then one on the lateral left to lower side near the apex of the heart. So again, still not anterior, posterior, because like she said, that will get in the way of getting good visualization of the coronary arteries when we're trying to look and see what's going on.
Yeah, same for us. So we wanted to be on the right-hand side, like not covering the heart that we're trying to get imaging on. But some patients have very little real estate to work with. And so if you put a pad on their upper right chest, it kind of still occludes what you're trying to see. So sometimes we'll even like wrap it over like the collarbone shoulder area just to make sure we have enough space to see all of the vasculature and make sure that we're, finding the vessels and clearing them out. Okay, so my next point, after you get the patient on the defibrillator, ready to use, like it is plugged in, it is working, the battery is fully charged, we don't have a dead defibrillator. Then let's start thinking about how we can support this patient as far as oxygenation and ventilation. Now, obviously, ABCs, right? If they come in not breathing, then that's your first priority. But this patient drove himself here. I'm assuming he's ventilating okay. As far as oxygenation goes, we're only going to apply supplemental oxygen if their SpO2 is less than 90%. And that is actually a practice change from when I started as a nurse. We used to be every patient got oxygen, but now our most recent evidence tells us you can actually cause harm from giving too much oxygen. So only if they're not doing well oxygen-wise would you support them with extra oxygen. Next, get good IV access. So yes, we do have to draw blood. Welcome to the ER. Every patient gets blood drawn. But the blood draw is almost like the icing on the cake. Just to get a baseline, I don't really need a troponin to diagnose an acute coronary syndrome because we're staring at the ST segment elevation. Like, yes, we will get it. We will get blood work. We will send it off. But our priority is getting that IV access. So question back to you guys. Do you have a preference where the IV access goes? What gauge replacing? What are your pet peeves with regards to IV access?
So you definitely want a large bore IV, preferably an 18 gauge if you can. More than one IV, preferably two. I mean, the more the better, but definitely more than one. And avoiding the radial area right here, because that's where we're typically going to go, is through the radial artery. Exactly.
The right radial.
So sometimes if it's placed high enough, we can manage to work around it, because then we have to put the TR band on afterwards, and sometimes it can get in the way or occlude the flow. So anywhere that's not near right radial.
Okay, so large bore, not right radial. In my facility, we try to do bilateral, and usually AC is kind of what we're shooting for. If you want a large bore, AC is usually your vein that's going to be the best. Okay, next is medications. Aspirin is a class 1 recommendation. So all patients that are having acute coronary syndrome are going to get some sort of aspirin. The recommendation is 162 to 325 milligrams of non-enteric-coated aspirin, ideally like the chewable baby aspirins, because those can be chewed up and onset is almost immediately. We'll give other medications like Plavix, also known as clopidogrel. I never say that one. Prasugrel or Effient or Ticagrelor, Brilinta. How do you guys say them?
Exactly like that. Clopidogrel. Prasugrel.
Yeah. Brilinta, Effient, Plavix. That's how I say it.
Yeah. She's like, I say the brand name because it's easier. I work with a doctor who will not talk with you if you are saying the brand name. Like you'll say, I remember telling him, I gave the patient Narcan. He said, you gave what? I was like, we gave Narcan. He's like, what did you give? As if he'd never heard of Narcan. I was like, I gave naloxone. He's like, oh, naloxone. I know he knows, but that's his pet peeve is no brand names. Okay, so I prefer brand names too because they're easier to pronounce. But yes, so we give those medications kind of to make the platelets more slippery so they don't get clumped up together. Don't tell the patient it's a blood thinner. It's not a blood thinner. It also will not break up the clot that they already have. It'll just help prevent new clot from forming. We may or may not also give heparin. Kind of depends on the patient and the timing. And we may or may not give nitroglycerin. More on that in a minute. Okay, next. In addition to the 12 lead and prepping for the worst case scenario with regards to V-fib pads and airway supplies, like I said, the patients may or may not get oxygen. They will probably get some sort of medication to prevent clots from forming, making sure they have good access, making sure that you have the patient in a gown. That is also ideal for the Cath Lab team. So we're not trying to strip them naked on the Cath Lab table. Sometimes the ER nurse is responsible for getting the consent signed. Sometimes the Cath Lab does that. I won't speak to what your facility has. I just know your facility's expectations. Make sure you explain to the patient what to expect next, and then that you are responding to any hemodynamic changes that might occur as their STEMI evolves and as the medications we're giving might affect their vital signs. Okay, note that I did not say Mona. Did you guys learn Mona in nursing school for all chest pain patients?
Absolutely.
I was just going to mention that too. And it's still something that they're still teaching. It's so outdated.
I know. Okay, so yeah, I also learned Mona, morphine, oxygen, nitroglycerin, aspirin. In fact, I was told every patient with chest pain is greeted by Mona. That was the catchphrase, right?
Oh, wow.
But the only mandatory one on that acronym is the aspirin. Mm-hmm. The rest are kind of debatable, right? Morphine may do more harm than good. And so it's really just reserved for patients who are still having chest pain even after the nitrates, right? Mm-hmm. Oxygen, as we already talked about, can also cause harm. Oxygen is a drug, so we only give it to patients whose status is less than 90. Nitro also carries some risk with regards to blood pressure and preload. And so we're very selective in who receives the nitroglycerin. But I definitely give it pretty frequently, even in STEMI patients. But yeah, still aspirin for sure. So no longer does Mona greet every patient with chest pain like she used to. Okay, so I think that covers the ER stuff. Can you guys think of anything else that I missed with regards to the ER nurse's role in getting this patient off to the Cath Lab?
One thing that I would say, and Caitlyn, you can definitely chime in with this, is that because we're already kind of behind the 8 ball with this patient, they came in not with EMS. Mm-hmm. We have to call in the cardiac Cath Lab. And usually, it's usually 30 minutes. They have to be less than 30 minutes to be able to, the Cath Lab team has to be there. But we really want to try to get these patients as quick as possible and start getting that balloon up in that vessel. So we're already behind the eight ball with this patient. They're already decompensated. One thing that we have to do with these patients is sometimes we have to shave them. And that seems like it's not going to be that big of a deal. It doesn't take that much time. But I'm telling you, when you work a STEMI, it is amazing how quick things go. And that's just another step that can really help the Cath Lab team if you're able to shave bilateral groins as well as the right wrist if needed, to remove that hair, remove the hair that is now kind of like all over the place, because that's all stuff that we would have to do that can just be one step ahead to trying to get that vessel open for the patient. So it's just kind of like, I know that's like a low priority for this patient, but if you have the time and you could remember, that's super helpful for the Cath Lab.
Yes, I totally agree with Sarah.
Good reminder. Yes. Do you guys have like a phrase that you say to the patient right before you go in to give them a mohawk? What do you tell the patient when you're about to give them a really unique haircut down there?
You know, if it's a STEMI patient, I'm not making small talk.
Most
to be
of the time I'm just we're going to prep your groin.
Yeah, I'm business. I'm telling you, like a STEMI case is completely different than a regular scheduled
elective cath,
left heart cath. That's when I can play around with the patient. But if it's a STEMI, we're business. Like we are moving.
All right.
We're like, I ain't got time to talk.
We are prepping the groin.
Yes.
None of this, I'm giving you a mohawk. We're going to give, no, just like.
No questions asked.
People that are like running around, like your circulators, trying to get ready and like everybody, it's amazing. If you could watch a STEMI at some point, like it really is. It's like a beautiful dance. It's wild to watch.
It's like a well-oiled machine. And everyone, I feel like when you've worked there for a while, knows their part. I mean, you can kind of read each other when you've worked with the team for long enough. And my coworkers are amazing. I love them. And we can literally read each other without even communicating. And we all find our role and what to do.
I love that. Okay, so for this particular patient, like I said, it's 5 a.m. So the stimulator was activated. The Cath Lab team is en route. It took him about 25 minutes to actually get him to the Cath Lab because they had to get from their homes, get changed, get the Cath Lab, prepared, all the things, right? He was given the aspirin, ticagrelor, nitroglycerin, IV heparin, just because we had some time to work with. Then, after the nitro, he became a little hypotensive. Nothing crazy, but a little concerning. 89/50. So we gave just a 500 cc fluid bolus. Blood pressure improved. The Cath Lab team arrived and woof, they whisked him out of the ER's hands and now he's on to the Cath Lab. Okay, so now, Caitlyn, he is in your hands. I'll just tell you right now what happened to this patient, then I have lots of questions to review about the details of what this actually looks like. So they discovered 100% LED occlusion. Makes sense, right?
Yep.
The stent was placed, yay, but during the procedure, the patient went into ventricular fibrillation. There was a brief moment of CPR and the fibrillation followed by ROSC after just one shock. The Impella device was placed for mechanical circulatory support due to cardiogenic shock, and the patient was then transferred to the ICU post-PCI. Okay, Caitlyn, I just dropped a lot. I was hoping you can help me break down some details of what I just said.
Yes.
So I'd like to pull back the curtain a bit and talk about what all happens in the Cath Lab for these patients that are having heart attacks. So to start, what happens on your end when you get the call for the STEMI, especially one that is flagged for a high risk?
So typically our on-call team consists of, there's 2 nurses, there's a cardiovascular tech. I work at a teaching hospital, so there's a fellow that typically scrubs. And then at my per diem job that I work, it's usually a tech that will scrub. And obviously the interventional cardiologist on call. Usually the interventionalist will call one of us and just give us a quick rundown of the situation, what's going on with the patient, which is actually very helpful. Because at least on my way in, I can kind of know what I'm walking into. And usually I'll just kind of run through a mental checklist in my head, right? Like when I get there, I'm going to do these things. I'm going to make sure that this is there, I have this. But whenever I leave at the end of the day before I go home and I'm on call, I always check the room to make sure I have everything that I need. I check the equipment, and we have a STEMI box that has all of the supplies that we need to drop on the table for a PCI. So that definitely helps me feel at ease because it kind of cuts down on some time. But when I get there, I'll always check to make sure code cart's there, obviously. We have ACLS med trays that I'll pull out, make sure that you have working suction and actually test it to make sure it works. Ambu bag, I manually check the defibrillator, make sure we have a temp wire with spare batteries. We keep our mechanical circulatory support devices in like a back room, make sure that they're always plugged in. So if I know it's a super sick patient, I'll just take the Impella out, have it there at the end of the table. So that way, if they decide to put one in, it's like, okay, it's right here, it's ready to go. I just have to load the purge cassette in there and they'll hand it off. Always check to make sure that we have enough IV pumps. If it's a super sick patient, you're going to have a whole tree of pumps. And yeah, I think that's mainly like what I check when I get there. And then I'll look up the patient. And this is kind of what I struggled with when I first came to the Cath Lab. It's not like ICU where you know everything about the patient, right? So especially when you come in for an emergent STEMI, you pretty much know the basics. So, I mean, I always check their allergies, code status, their past medical history, what meds they got in the ER. I'll read their echo if they had one in the past, and cardiac history. And then I'll check their labs, but they're not always back in time. So a lot of times you get them resulted when you're mid-PCI, right? So yeah, that's usually what I do when I get there. And the ER will bring the patient down to the Cath Lab, which is nice. At my other per diem job, the nurses will go and get the patient in the ER.
Cool. Okay, and then can you explain like what differentiates a quote high-risk PCI from just a standard one?
So that's actually a really good question. And I think it can be subjective, right? So like what I consider high risk might be different from what somebody else considers high risk. Mainly a standard PCI, that's going to be your elective outpatient, right? They get a left heart cath, they could come back for a stage PCI, or they do it then and there. Usually they don't have that many comorbidities. They may have some. They're usually younger and have a better reserve than, like, for example, patients who have multiple comorbidities like diabetes, high cholesterol, if they have valve problems like aortic stenosis. Those types of patients can't tolerate ischemia for a long period of time. I've seen a lot of PCIs that, I don't want to say didn't go well, but there were complications because they don't have much of a physiologic reserve when they put the balloon up, and then they're ischemic. So a lot of times when they do a PCI, they'll put in an Impella for support. So they call that an Impella-assisted PCI. Those are usually planned. Sometimes the patient's anatomy. So do they have left main disease, like an unprotected left main? Do they have a trifurcation lesion if they have a ramus, or bifurcation lesion? Those can be difficult to fix, increase the risk of complications.
I don't think everyone knows what a ramus is or a trifurcation lesion. You just talk a little bit about the anatomy there, what makes that extra complicated.
So it can be tortuous too. So just trying to place like those stents in those balloons, like it increases the risk of coronary dissection, like going through the wall of the vessel, damaging the vessel itself. And there tends to be more plaque too at those bifurcations, which can increase complication risks.
Sarah, did you want to add anything to that in your experience with those unique anatomical abnormalities?
I know, it's such Cath Lab language.
I think one thing that I notice as far as patients being termed a high-risk PCI is that maybe they come into the cardiac cath lab, and whether that's going to be a scheduled left heart cath or it is something like a STEMI or an NSTEMI, that they go in, they get them on the table, they see that this patient has multivessel disease. So at that point, a patient, if they're able to get one occlusion in order, like the worst occlusion, that's like the culprit of a STEMI, they may try to go after that. But usually they're going to say, you know what, we need to medically management, and we're going to consult a cardiothoracic surgery because this patient needs to have a CABG. Mm-hmm. But then the cardiothoracic surgeon comes in and they're like, I'm not doing it. They are not a candidate for CABG. And so then it kind of gets punted back to the cardiac cath lab team, the interventional cardiologists. And they're like, okay, let's see if we can now maybe go after something. That patient would be considered a high risk PCI. And so that is like, it could be a stage thing. It may be where Caitlyn was saying that they have Impella in for Impella support during that procedure. So those patients are also considered to be a high risk PCI patient as well.
Okay. All right. And then, Caitlyn, can you describe your actual role during the procedure? Like, what kind of stuff are you managing in real time? What are you documenting? What are you assessing for? What is the cath lab nurse's role?
One thing I just wanted to add to the high risk thing, sorry, I'm going to backtrack for a second, is if a patient has a low ejection fraction. That's a big reason for high-risk PCI.
Which this patient we knew coming in
Yes.
had an EF of 35%. Like he told us that.
Right. Yep. So they'll prophylactically usually put in an Impella for support during it, and then they'll take it out as long as the patient's doing okay afterwards.
So tell me about your role during a cath.
So nurse's role is primarily you're circulating typically, so administering sedation, making sure that the patient's comfortable. If it's a really sick patient, you're hanging a lot of vasopressors, starting some inotropes. You have 2 nurses, thankfully, so usually one is kind of standing at the monitor watching for any kind of arrhythmias or anything like that. The other one is, like spiking meds and hanging different pressors. If you are putting in an Impella, the tech is really good about coming in and helping and just handing off equipment for us because it can get really busy.
So let's talk about the role itself, like in the moment. Okay, so the interventionalist, their hands are sterile, right? They're doing this procedure, they'll look on the screen.
Mm-hmm.
Like they're not really maybe watching the monitor, right? Their job is to open up this vessel, so they're watching the screen to look for that to happen. So it probably, if there's a V-fib arrest, it's probably going to be the nurse that notices it this first. Okay, so let's say you are the nurse. You see V-fib on the monitor. What do you say? And then what happens next? Because from what I have seen, it is a bit more challenging doing compressions on the Cath Lab table with all of the radiography stuff all around you. Just walk us through that.
So typically in my lab, if there's any kind of rhythm change, right? So even if it's like a non-sustained VT, we always say rhythm, and that's kind of our key word that, hey, there's a change, let's do something about it. Obviously, the patient goes into V-fib. That's a big emergency. We'll alert them, and then we just shock them at 200 joules right away. The Cath Lab is different because you have a lot of equipment around you. The C-arm is over the patient, so it's sometimes really hard to get to their chest. Depending on whether they think the arrest is related to the artery, they'll just continue working, and you're kind of working around that, which is really hard because the C-arm is over the patient. So when you're doing chest compressions, you're kind of at an angle. You're also wearing lead, which that is very difficult. It weighs a lot. It's definitely not easy.
So as far as body positioning, putting all of your body weight over the patient to provide compressions is a little bit more difficult when there's a C-arm in the way.
Yes.
I know I went to a code one time in the Cath Lab, and Kyle, one of my rapid nurses, who's he's a pretty fit dude, they had him do compressions because you couldn't use body weight. You had to just kind of put your arms out perpendicular, you know? And so he's doing compressions, and I'm watching the art line, and even with this big, strong Kyle, the blood pressures were 60 systolic on the art line. But then finally they moved the C-arm out of the way, and he got up on top of the patient, and it was 140 systolic. The cardiac output, the pressure he's able to create just with body positioning was pretty impressive to see. So it's definitely difficult running a code in the Cath Lab with the C-arm in the way. But like you said, we could run the code all day. If we don't open this vessel, this patient's not coming back to us. So they keep doing the procedure even while delivering compressions, which is different than what we're used to.
And one other thing I want to add that makes it difficult too is if it's 2 a.m. in the morning, your resources are kind of limited, right? So it's kind of a 3-man call team. It's 2 nurses and a tech.
So, Caitlyn, what are some of the top complications that you are prepared for during PCI? Obviously, arrhythmia is a pretty common one, but are there other things that you're looking out for, things that you've seen before? How do you respond to those things?
Definitely. So one of them is a coronary dissection. You can see a coronary perforation, which is extremely bad. I've only seen that once. And they will deploy a covered stent. So whenever I'm in the room every morning, I always check to make sure covered stents are there because that's something that you want to get right away. You don't have time when that happens. With a coronary perforation, you could see cardiac tamponade because then you have bleeding out into the pericardial space, and it happens very quickly, especially if they got heparin. There's something called no reflow, which is pretty interesting. That's pretty common to the Cath Lab. So it's believed to result from microvascular obstruction during a PCI. And so it's exactly what it sounds like, no reflow. So it's very slow flow down the coronary. And they usually treat that with intracoronary nipride. Like you said, arrhythmias, especially if we're intervening on the right coronary arteries. The right coronary artery supplies the SA node of the heart. So what can happen when we balloon is you're occluding that flow to the SA node. So you could see bradycardia, you could even see a heart block. So, whenever we intervene on any vessel, I always have emergency meds available, but especially atropine for those cases. Bleeding is obviously a big one. So with femoral access, retroperitoneal bleeds. And usually those don't notice right away. When the patient's in recovery, they may start to develop back pain. And that's usually the indicator. So when it's femoral access, they start to have back pain, then start questioning, is there something else going on?
Sarah, anything else that you remember from your Cath Lab days, complications or things that you were prepared for?
I think one thing that I will just add is that, and I noticed this specifically because I was a ICU nurse that went to Cath Lab, that sometimes these patients will also have real respiratory issues. And we are giving them at times, moderate sedation. So we have to be on the lookout of that I've had some situations where patients have decompensated from a respiratory standpoint. So all the things that Caitlyn said, but from a respiratory standpoint, patients can decompensate in that aspect as well, where we're having to escalate in both oxygenation and possibly even ventilation. So that's another component that could be a side complication, if you will.
The entire time they're laying flat too, which doesn't help.
Right. That's like every ICU nurse is like, clench up the sphincter, have to lay a patient flat, and lay them flat for like an hour, right? So yeah, definitely a cause for concern there. So to transition us from the Cath Lab to the ICU, can you give us an example, like let's say for Mr. James, what would the report sound like if you were giving report from your Cath Lab patient to Sarah, who's about to receive him in the ICU?
So usually what I'll do is just run through what's a patient's name, date of birth. So James Doe, he's a 62-year-old male, past medical history, hypertension, diabetes, chronic kidney disease, stage 3, heart failure, reduced ejection fraction at 35%, prior STEMI, patient's allergies are so-and-so. He's a full code. He presented today to the ER. He drove himself in with chest pain radiating to his jaw, diaphoretic. On presentation, he was tachycardic, likely like in the early stages of shock. The EKG showed ST elevations in V2 through V4, so he was having an anterior wall STEMI. The ER gave him 324 of aspirin, 180 of ticagrelor, gave him some nitroglycerin and IV heparin bolus. He was hypotensive, so they gave him a fluid bolus, and then we brought him to the Cath Lab. We went right radial. We found 100% LAD occlusion. He got 2 stents to his proximal LAD. We gave, I'll usually tell them, like 3 milligrams of Versed, 50 mics of fentanyl. I'll tell them how much heparin we gave. He got 2 stents to his LAD. And during the procedure, he briefly went into VF. We shocked him once at 200 joules. He converted back to sinus rhythm. We achieved ROSC. And due to cardiogenic shock, we placed an Impella. I'll let them know what the flows are on the Impella, what the placement signal is showing a pulsatile aortic waveform, so that helps you know where the Impella is positioned to make sure it's in the right place. And I'll give them a rundown of pulses too. So obviously the thing that we worry about with the Impella sheath, because it's so big, it's 14 French, you can occlude flow down the leg. So I always check to make sure that they have pulses afterwards. And I'll let them know what drips the patient's on. So if they're on 30 Alevio or, 2.5 of dobutamine. And yeah, that's usually about it.
Okay. Sounds good. There's your report, Sarah. They're on their way to you. All right. So, Sarah, this is like your bread and butter patient, right?
Yes.
Cardiogenic shock with an Impella. Sarah's like, bring it. All right.
Yeah.
So this patient arrives to you with vasopressors infusing, Impella attached. This patient is very, very busy. So when you receive a patient post-PCI with an Impella and vasopressors, what are your first priorities, Sarah? What have you prepared ahead of time, and what are you doing once they roll in the door?
Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that, because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode.
So hopefully, I'm hoping that the patient had a PA catheter.
I was just going to say, I totally forgot to mention that. How did I forget that of all things? That is like one of the most important things.
I knew that they were going to have a PA catheter.
Because you've been on call for 3 days. That's why.
It literally just crossed my mind. Oh my gosh. My brain is mush after work.
So prior to the patient even getting there, because they typically will just have a PA catheter and they don't have the same setup that we do. So I typically will set up my entire PA catheter as far as like the transducer and stuff prior to them even coming. And I'll get as prepared as I can. Usually my buddies are going to be there with me. Like if a patient's rolling in hot, which this patient is, it's not just going to be me landing this patient. I'm going to have other individuals come in there where they're going to be responsible for getting the patient on the monitor, transitioning from, the V-fib and transport monitor onto our bedside monitor, and maybe even possibly hooking up the PA catheter and getting that up on the monitor as well. So while she's giving me report, I'm kind of going around and checking everything. So I'm going to be looking at my groin site. I'm going to be looking at that radial band. I'm going to be looking at the Impella at the groin site. So looking and seeing where it's actually locked at the centimeter marking, because that's really important. And I want to validate that with my Cath Lab nurse saying, okay, was this marked at this when you left? Okay, great. I still see it. And then I'm going to look at the console. I'm going to look and see and validate everything that they said, including the purge fluid that they have. So typically, I don't know, Caitlyn, are you using heparin usually in your purge fluid?
V-fib with some heparin, yeah.
Yeah. So I want to know that because many times we're trying to transition over to bicarb for our purge fluid. So I want to know if they're on heparin. And then I also am going to be checking those pulses. So she may say, hey, they have good pulses. I'm sorry, but I'm going to go down there and I'm going to validate that information. Right. If I have to go get a Doppler, I'm going to go to Doppler, have someone go get a Doppler for me and validate that information prior to them leaving, because that's going to be very, very important for me to know. And then after that, I'm going to really be looking at my patient. All of this is happening all at once, right? We don't ever do anything just in isolation as nurses. I'm assessing my patient. I'm looking, are they still diaphoretic? What are my vital signs looking like? How is their breathing? How are they feeling? Are they talking to me? And what are they saying? Do they have chest pain? What's my, ECG tracing look like? And what are my PA pressures that I have? The other thing that I'm going to be asking Caitlyn is, what was my LVEDP when they were in there, if they were able to obtain one, because that's really valuable information. So that tells us our left-sided filling value. And of course, this patient has a massive LAD occlusion, which is right into that left ventricle, which is why they went into cardiogenic shock in the first place. So that left ventricle is not able to mobilize that blood out. And so because of that, we're going to have kind of stagnant blood, if you will, being in that left ventricle because it's not able to mobilize it. So that's really good and valuable information for me of knowing what is the patient's filling pressure on that left side when they were in there, if they were able to obtain it. Sometimes patients are too sick where they're like crashing and burning and they're like, I can't get LVEDP. But other than that, I'm also going to be looking at the placement waveforms and the signals on the console for the Impella. And then my buddies are going to be calling the echocardiogram, to come to the bedside and evaluate the patient for placement of the Impella. So there's a lot of stuff that happens all at once. I was going to make a joke and say the very first priority for me is untangling the ball of IV tubing. But, that comes part of it, right? The last thing I will say is that this patient's on vasopressors, okay? And maybe they do have stocked Levophed. Maybe they don't. Maybe they had to mix it. So I want to be validating and tracing those lines and seeing where those medications are infusing at and double checking the rate. Those are all safety checks that we do with any admission as critical care nurses or any nurse, period. We should be validating that information. So all of this, it seems like that's a lot, right? But you have hands on board and it all happens very quickly. Depending on the acuity of the patient. If they're still, not doing hot, then this is going to look a little bit different, right? It really just depends on the stability of the patient as well.
So there's two things that both of you guys kept mentioning. I want to circle back to it. And that is placement of the Impella. Like, where is it actually living at the moment, which is super important. Can we backtrack a little bit, Sarah? Can you just describe what exactly the Impella is doing? Like, Where is it sitting in the heart? How is it supporting the heart? And then what's the big deal of this whole placement? What if it does move a little bit? Why is that a problem?
Right. So the way the Impella works, and we're talking about left-sided support because there is right-sided Impellas. So we're talking about left-sided support. So this is going to go into the left ventricle. The Impella has two very important ports on it. It has an inlet and it has an outlet. The inlet is going to be what's sitting in the left ventricle. And there is a little motor that is called an impeller, and that spins and it's going to basically pull blood from the inlet out through the aortic valve and then push it out through the outlet, which is sitting into the ascending aorta. So basically what that's doing is it's offloading that left ventricle. So again, we have this left ventricle that doesn't have very good squeeze. So it's going to pull that blood from the inlet and take it out with the impeller, which is going to be influenced by the P levels that we set. So the more P levels that we have, the more support, the more that it's able to kind of draw that blood out up through the Impella and go out through the outlet. And then eventually it's going to obviously go through systemic circulation. So that's kind of how an Impella works. The placement is really, really important. Number one, you don't want it to be too deep, okay? If it's too deep, then it can do a few things. You can have left ventricular perforation, you can have arrhythmias because it's tickling the left ventricle, and it's obviously not going to be offloading appropriately because the outlet may be too far in where it's actually not able to pull that blood and have it go across the aortic valve. So it's really important that the placement of the aortic valve is what they're going to be looking at. So when we go and get an echo, that's one of the kind of check-in things that we do for an Impella that lands into the ICU. We're looking to see how far from the aortic valve the inlet is. It's a very specific centimeter marking. Mm-hmm. Now, if it's too far out, so then it's not able to offload either, because then the inlet, which is pulling blood from the LV in proper position, could be further out of the aortic valve, which is not going to get good offloading as well. So there's the placement is super important, not only for the function, but this also leads to things like hemolysis. It can lead to a few different complications if it's not in good, proper placement and positioning.
Okay, so you have this new patient, you're assessing, I would see, how is their perfusion doing? Like, is this Impella actually helping their cardiac output? Are they still like cold and clammy in their extremities? Or are they a little bit better perfused? They're kind of pinking up and, warm to touch. But also looking at the monitor for signs that this device maybe has moved. So you're constantly watching that. Are there any other risk associated with the Impella that you are closely monitoring for whenever this patient's in your care?
Yeah, I mean, there's a whole slew of risk, in all honesty. I mean, it's a lovely device, but as with anything, it does come with risk. So hemolysis is one of them. The Impella device in and of itself is preload dependent and afterload sensitive. So that will also influence the functionality and how well it's working. So preload dependent, the LV has to have enough volume in order for it to actually offload the LV. So one alarm that could possibly happen would be suction alarms. It's a very frustrating when that happens. It could be from positioning, but it could be that the patient just needs a little bit of volume. So that's also one thing, which if it's not corrected could lead to, number one, not optimizing the patient well with the device, but also can lead to hemolysis. Of course, bleeding is going to be a big factor. This is a 14 French sheath. That's huge. So patients can have groin complications. It's really important that when we go and we have an assessment of that groin, that we're evaluating that the patient isn't having bleeding around that, not having a hematoma, as well as possibly an RP bleed. One thing that's really helpful and beneficial is we need to make sure that we're maintaining the angle of entry that the cardiologist actually had when they stuck the patient. So unlike a central venous catheter, which is laying more flat next to the skin, the Impella sheath in the catheter is going to be almost like a 30-degree angle from the skin on most patients. And so typically, in order to maintain that angle, we have to have a little bit of gauze underneath it in order to not have it give pressure to the artery that they actually stuck. So that's one method as far as making sure that we're addressing if there is bleeding and making sure that we can hopefully mitigate that risk of bleeding. In addition to that, these patients are going to be on anticoagulants in order for the Impella to not have other complications, such as having clots develop. They have to have some type of anticoagulant. There's been a really big push to move to bicarb. So I think most facilities are using bicarb because heparin is another fluid that you can use in the purge system. And most patients are going to have systemic heparin as well. But we have to monitor those ACTs very closely, making sure that they're in with a window of 160 to 180. Because obviously, if it's higher, the blood is going to be thinner, higher risk of bleeding. The other complication is that patients can have limb ischemia. This is a huge sheath. What if a patient has peripheral artery disease? You may not know that, like the patient may not know it when they come in for a STEMI. So you can have limb ischemia happen with these patients. So we really want to be monitoring the patient's pulses, temperature, what they feel. There's also some devices that you can actually put sensors on the skin to monitor that. So there's a few different methods that you can do that. And then, of course, just the patient's hemodynamics. These patients can also, RV failure can start to come up, can start to kind of develop with the Impella device. So there are a lot of complications, unfortunately. But they don't always happen. But you have to know all of them in order to make sure that you're keeping an eye.
And be ready to respond to them.
Yes. Recognize and respond and mitigate if you can.
So Mr. James keeps having little runs of VT, 4, 5, 6, 10 beats. Can you talk a little bit about reperfusion arrhythmias and how you respond to them?
Yeah. So there's a few things when it comes to reperfusion arrhythmias. So reperfusion arrhythmias basically happen after the vessel has been reperfused. So whether that's going to be through thrombolytics or hopefully through PCI intervention, right? So now we have a vessel that distal to that vessel, the tissue was not having good, adequate blood flow. And so we have ischemia. That's the whole purpose of, the whole pathophysiology basically behind a STEMI. We go open that vessel up, and then all of a sudden, this tissue has this rush of blood that is oxygenated going to this tissue. So there's a few things that can happen with reperfusion injury. So the tissue prior to the reperfusion switches over from aerobic metabolism to anaerobic metabolism. There's also changes with the intracellular calcium values with this. So once we open that vessel up, we have this massive, kind of flushing of oxygenated blood. Oxygen, as you kind of were mentioning way earlier, we love it, right? It's helpful, but it can also cause harm. There are free radicals that can take place. And so that is a reason why patients can have some reperfusion arrhythmias as well. So there's a lot of pathophysiology behind why patients may have this, but the arrhythmia is also dependent on what's going on with the patient. So if it's something like ventricular tachycardia or V-fib, so most of the time, reperfusion arrhythmias are going to be ventricular in nature. But if it's something like V-fib or V-tach, usually that is indicating that a patient has ongoing ischemia and damage continuing. That, they may have opened the vessel, but there may be small little micro thrombus a little bit further down. So that tissue is still going to be becoming ischemic. So it could just be an evolving ischemic tissue if it's related to those arrhythmias. Another arrhythmia that is quite common is accelerated idioventricular rhythm, which is really not that big of a deal. We're going to monitor it. And that's actually telling us that patient, the tissue is actually getting good blood flow. So it's really depending on what type can kind of say what's going on with the patient. So if it is like V-fib, V-tach, a lot of PVCs, that's more like this is continuing to have some ischemia happen with this patient. The other one, accelerated idioventricular rhythm, is likely because it's true reperfusion. We have this massive rush of blood, this change of calcium where it's a highly excitable tissue now leading to this arrhythmia happening.
Yeah. I wanted to tell a quick story. When I was a new CVICU nurse, fresh off orientation, I had a patient who kept having runs of a wide complex tachycardia. And so I'm telling the more senior nurse in the department, my patient is having these runs of VT. He's like, it's not VT. It's just idioventricular reperfusion. It's not big. It happens all the time. It's normal stuff. And I was like, okay. But of course, still says to my patient, how are you feeling? And their chest pain's getting worse. Turns out the stent actually reoccluded. Oh, so wow. The runs of VT, the worsening chest pain, I had to at our unit, you couldn't just attach the 12 lead. You had to call for a 12 lead. I ended up calling for a stat 12 lead, and that's how we ended up catching it. But yeah, it was not just an idioventricular little normal stuff. It actually was VTAC, and he actually was reoccluding, and he did go back to the Cath Lab.
Yeah, and that's the complication that we have to watch out for. So regardless of what type of arrhythmia the patient is having, even though, accelerated idioventricular rhythm is usually no big deal, we're not just going to sit on it. We're still going to do our due diligence as nurses and evaluate what is the reason. We never want to look at any type of arrhythmia. I don't care what it is or how benign it may seem. We still need to be asking ourselves, what's the cause? And is there something that I need to do to fix this? And should I escalate? And regardless, I would be notifying the provider anyway, like, hey, this is what's going on with the patient, right? And one thing that you mentioned, Sarah, is that with, this patient, they had an LAD occlusion. So we know which leads already that we need to keep an eye on. Normally on our monitor, we have two leads that are available, right? So we want to make sure that we're having at least one of those leads. Maybe lead 2 is, our standard, whatever, it's always there. But one of our V leads, we want to make sure that it's going to be able to catch in case that patient does have reocclusion. We're able to monitor that with that lead. And of course, listening to our patients always.
Yeah, that's a really good point.
Yes, thank you. So taking together both information from the monitor and information from our patient to make the best clinical decisions. Okay. So let's talk a little bit more about like the long-term care of this patient. Obviously, it's crazy initially, but these patients are still pretty complicated. Even weaning them off of the Impella can be risky and challenging. Can you just briefly describe what is the ICU nurse's role in moving the patient towards coming off of the Impella? Like, what are we trying to accomplish? What are like the goals or checkpoints that we need to meet for them to be able to kind of wean down the flow rates and get off this thing?
So normally with these patients, we're going to be doing, not only are we going to be assessing the patient, the console, yada, yada, every hour, but these patients are going to have routine labs. And these labs are going to be the ones that we want, typically we're going to be evaluating are going to be like lactate levels. We may be looking at AST, ALT, things that provide us with information in addition to the clinical picture, what we obtain with a PA catheter, all that information. But these lab values can also provide us information on, are we having tissue hypoxia? Because that's why we have this, right? We want to have optimal perfusion. So we want to make sure that our perfusion markers are good. If they're not good, then that's obviously a problem. The patient's not able to tolerate weaning. If we do wean, we're still going to be monitoring those things. We want to see, did the patient's index drop? Did the patient's CPO worsen? Did the patient worsen? What are my perfusion markers telling me as I'm weaning this patient down? Are they good? Are they stabilized or what? And then that will allow us to obtain information to evaluate how this patient is doing as far as weaning the Impella down. And along with that includes their pharmacological agents that they're on. So have we been able to wean down that levofed? Hopefully we have. She said that they're on 30 of levo. Well, we're not going to be weaning this patient down on 30 of levo, right? We want to get that levo down first and then start weaning down the Impella. And typically these patients are going to have some diuresis that needs to happen as well. So we want to try to optimize the patient as much as possible. Wean down the pharmacological agents typically. They may be on a little bit of dobutamine as well still. And then we're going to try to wean the patient while observing and reassessing the clinical picture, the Impella, the PA catheter values that we obtain, as well as our perfusion markers. And that will allow us to continue to evaluate, can we go, what is our next step? And then if they still look good and we're able to come down to like a P3 level, which is very low support, then we will be able to explain. The other thing that I do want to say is that you can also see kind of the native heart function with an Impella can give you some information on the patient's native heart function. So let's say, for example, I've had this happen, probably about 2 months ago. I had a patient, STEMI, came in very similar to this, and patient lost pulsatility on their Impella. That means they have no native function of their heart. Heart is completely depending on the Impella at that point. But you can also see in a different area, not in the main console area that you typically would monitor, you can actually see some information on the native heart function, and that can give you some information about how well this patient's doing too. So there's a lot of factors that go into it. But remember, the purpose of this is because the patient is not meeting perfusion, okay? And so that's what we really want to be looking at. Are they able to come off the support and maintain perfusion?
Final question. So my experience with Impellas was 12 years ago. They were a little newer, and like they were reserved for like the sickest of the sick patients. Like every Impella patient's like intubated, sedated, like extreme cardiogenic shock. But now I've noticed they're placing them earlier on as far as in like the cardiogenic shock spectrum. These patients sometimes are still awake and alert and interacting with you, even with the Impella. So can you talk about what are the things that you're educating the patient and the family on with regards to their device, some safety risks, things they should and shouldn't be doing? What is the nurse's role in mitigating risk when teaching the patient?
So one of the biggest things is we have to be educating these patients on the groin precautions that they have. And part of that is that they're going to be relatively flat, which, depending on how long they're on the Impella device, can be quite uncomfortable for patients. With that, they should not be bending their knee. So oftentimes, if they are not on mechanical ventilation with continuous sedatives and analgesia, then we'll usually put a knee immobilizer on the patient as a gentle reminder that if they would try to bend that leg, that they can't. Now, the patient can still turn side to side. And I want to stress that they can still be repositioned, even if they're flat. But it's the flexion of the groin that we really have to monitor. So that's a large part of the education, as well as just kind of like, what are the next steps? How are we going to get this out? They can still eat. So just being careful with them. You may have to assist them with eating because, again, they're kind of like laying flat. You can, of course, position the bed a little bit, tilt the bed. But I mean, imagine trying to eat, and then try to treat their discomfort as much as possible, because it can be uncomfortable especially because some of our patients are a little bit older. Maybe they have some underlying musculoskeletal issues to begin with, and now they have to be pretty immobile for who knows how long. Could be up to 5 days if they're really sick. So all of that is going to be probably the biggest education component, is the groin precautions and what is the next step. So keeping them informed as much as possible can help with their anxiety level too, because they just had a huge, massive STEMI. This is a form of life support. No one was expecting this, them or their family. So all of that is anxiety producing. So trying to keep them as informed as possible, validate their feelings if they have them, and teach them on their groin precautions. And then try to kind of start throwing in that, when you go home, you're going to have these medications and you have to keep taking this medication, or else your stent is going to, occlude again. And you don't want to have that happen. But sometimes that's saved, after explantation and things like that. So a lot of education, I would say most of it is around reminding them that you have this massive device in your groin and you can bleed.
Yeah. In the gentlest but clearest way possible, communicating that.
Yeah, but sometimes, you've said it a million times, and sometimes you do have to be very direct with patients. I mean, sometimes you do. That's the reality of our jobs, that sometimes they do need to hear that, no, I'm telling you, you will bleed out and die very quickly, because it's true.
Yeah. Yes, that is patient advocacy, is communicating clearly. All right. Question for both of you. What is something that you wish other units understood about your role in this STEMI timeline? Anything that you feel like people don't know or misunderstand or maybe misassume about what your role is and how you impact the patient's care?
I'm very happy that I had the experience of working in the cardiac cath lab, because it gave me a different perspective. I really do think that all ICU nurses, if they're taking devices or taking cath lab patients, they need to go spend a day in cardiac cath lab to see how it is. In general, regardless of ER, floor, cath lab, OR, we need to give grace to each other. Okay. What a priority is for me as a critical care nurse is not the same priority as a cath lab nurse or an ER nurse. And that's okay. That's why we have different specialties. And I think as much as we can, try to remember that our true priority is to do what we can in the best of our ability for that patient. And that looks different in different areas, which can be hard sometimes. Sometimes we're all human. Our resources may be low and we may get snippy at one another. But I think that as much as we can, we just have to give grace and ask questions. I think that rather than make assumptions, that sometimes asking questions is always best. And then communicate. We're all adults. I'm a very direct communicator. So I have a very good rapport with my cath lab team. If I'm like, hey, you know what, like next time, it would be helpful if this was the case, or whatever, so that way you continue to build those relationships rather than create barriers to them.
Yeah. I think going off of what Sarah said too, I very much agree with that. And I think sometimes the Cath Lab can get a rep for being like really direct or just, like to the point. But I think it's because people can be so focused on like, we're focusing on getting the patient on the table and time is muscle, right? So I think sometimes people can take things personally. I know I've been guilty of that too. I think we all do. So I totally agree with her, just giving each other grace and like knowing that we're there for the patient at the end of the day.
That's good. All right, final question. If you were precepting, say, a new grad in caring for this patient, what would you prepare them for before the patient rolled in the door? Like, what's something that you want them to know and to keep on the top of their mind as we're caring for this patient in the Cath Lab and then as we're caring for the patient in the ICU?
I think that even on arrival, say if the patient looks stable, quote unquote, they can easily become unstable in a matter of seconds. Like you were saying earlier, right? So they're awake and talking to you alert. They can go into V-fib in a second. I think that it's really important to be able to anticipate what is the worst outcome in every situation, right? And being prepared for that.
That's good. How about you, Sarah?
She literally stole the word out of my mouth. I was going to say
my mind is working.
When it comes to critically ill patients, one of our roles is to anticipate the worst case scenario and know how we would possibly respond. And if you are a new grad, you may not know what the worst case scenario is yet. Okay. And if you do, you may not know how to respond yet. So what I would say is that just remember that this might be your patient, maybe not because you're a new grad and this patient, there's steps to be able to take these devices, but we are a team at the end of the day. And if you need support, if you have questions, that's where we rely on each other. I have 16 plus years of critical care experience. I still rely on my team. I still ask them questions. I'm still reaching out and they're doing the same for me. I still learn from my teammates. So just know that if you ever feel like, you know what, I'm not really sure what's going on, but something isn't right, call a buddy in. Call a buddy in, have them take a look. If you're like, I know this isn't right, but I don't know what to do with the information, call a buddy in, The other thing that I would say is that sometimes with being a new grad nurse, and this is just because you're new, is that you can sometimes be hyper-focused on one thing. And I will always encourage you to take a step back, okay? Remember that thing, but take a step back and look at the entire picture. Because once you're able to look at the big picture, then you're able to have a very clear idea of what's going on. And you don't want to become so hyper-focused on one thing that you miss all of this other stuff that possibly is happening.
Yeah. That is a great point to end on. Well, Sarah and Caitlyn, thank you so much. This was a really good episode. I love that we tied in like our 3 departments and our 3 expertise into like talking about this patient's case through the different stages. So thank you guys for your time today. I really appreciate you sharing your expertise with my audience. And thank you, audience, for tuning into this in-depth case review and conversation about high-risk STEMI care. This episode highlighted the importance of communication, preparation, and the skilled nursing that's required across every touch point of this patient's care. So until next time, stay sharp, stay ready, and keep advocating for your patients.
Bye.
Hey guys, real quick. I can't believe I recorded this whole episode and forgot to give my friends a chance to tell you where to find their awesome resources. So Caitlyn, you can find her at ICU Nursing Notes by Caitlyn. It's Caitlyn with the Caitlyn. I'll put the link in the show notes. And then Sarah Vance, her handle is ICU Nurse, but it's ISEE, like I see you, friend, you, and then _nurse. So ICU_nurse is her handle. Both of them have such valuable resources to support you as a bedside nurse. Please check them out. Again, links in the show notes. You're welcome. Okay, that's it. Adios.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.